everybody. The Egyptian Vitreous Society welcomes you to the new program, AGVRS Around the Retina World in 30 Days. For a whole month, we will gonna travel around the Mother Earth, visiting different countries in different continents, and meeting dear friends and distinguished retina doctors and retina surgeons, not just to discuss and exchange knowledge about retina and retina surgery, but also we would go and also know a little bit about the culture, about the habits, maybe a little bit about the history, and maybe about the cuisine of each country. Today, we're traveling north to a very distinguished country, which is Germany. And when we mention Germany, we always remember precision, consistency, and quality. And today, we have a very dear guest, Professor Peter Schurman, and we welcome you, Peter, in this program. It's nice to have you with us, and thank you for accepting the invitation.
Yeah, dear Sharif, thank you very much for the invitation. It's an honor to be here with you.
Okay, I'm going to give a brief introduction about Peter for our audience. So Professor Peter Schurman is the head of Department Eye Clinic Sulzbach, Knappschaftsklinikum, Saar, Germany. Professor Schurman is a clinician scientist, and he has over 200 original scientific publications in international reference journals, as well as 30 book contributions. Professor Schurman is a world-class vitreoretinal surgeon. In addition, he has a wide experience as well in corneal transplantation, stem cell therapy in corneal diseases, trauma reconstruction, glaucoma, and cataract surgery as well. Together with other collaborators, he recently introduced new surgical techniques in the management of refractory, recurrent, and large macular holes. In addition, he has a very wide and long experience in electronic visual prosthesis, which will be the topic of today's meeting. We were happy to have Peter in Cairo 3 years ago in the annual meeting, and this is a picture at the live surgery, and we really learned a lot from Peter during that meeting, and it was a pleasure having him in person together in Cairo, and hopefully we'll have him again in future meetings. Just for our audience to know a little bit about Germany, because this is a 30-day tour, so we will visit each country, so maybe we get to know each country a little bit. Of course, Germany, this is in English, Deutschland in German, and Alemania in Spanish and in Arabic. We say Almania in Arabic, so this is the name we pronounce Germany in Arabic. As you can see, Germany is in the heart of Europe, having common borders with Western and Eastern European countries. As you can see, to the east, you have Poland and Czech Republic. To the south, you have Austria and Switzerland. And to the west, you have France, Luxembourg, Belgium, and the Netherlands. And to the north, you have the Scandinavian countries, starting with Denmark. Just to point, where is the location of Saarland? I think, if I'm correct, it is, where's the red arrow? It is in the western, southern part of Germany, and it's on the other side of the capital, Berlin. So this is where Professor Schurman is now joining us. So this is a brief introduction about Germany and about Peter. Peter, we'd like first, in the first half of this meeting, just to know a little bit about yourself. Can you tell us about where did you go to medical college, your residency and fellowship?
Yes, first of all, thank you very much for the kind introduction. Yeah. Medical university, it has been a long time ago. So I finished university in 1996. I did my study in Essen, which is a large tumor center, and in Paris. So about half the time in Paris. And I thought that I will never come back from Paris. It was really a nice time as a student, but it happened that I came back, and I started my residency in 1996 in Cologne with Klaus Heimann, who was one of the pioneering ophthalmologists in vitrectomy back in the 70s. So this was really inspiring. And after residency, I changed to the University of Tübingen, which is the largest research center for eye research. There are about 80 researchers, so more researchers in ophthalmology than medical doctors in ophthalmology. So this was mostly my background, why I was inspired to do continuously research, and I did all my surgical steps in Tübingen, which is a large retina center also. And after 10 years, I was appointed head of department here in Sulzbach. And Sulzbach is a special clinic. It is a non-university clinic, but it's the largest non-university clinic, and it's by tradition the largest retina center in Germany. We are responsible for all the southwest of Germany. So I think 90% of all retinal detachments come here far away to Sulzbach, which is really directly at the border of France. I can see the border of France from my window. It's 10 minutes with a car. And yeah, this is a special thing in Sulzbach. It's in the middle of nowhere, but by tradition, since 100 years, there is a very reputed, well-reputed eye clinic, and that's the reason why I decided to accept this appointment, and I never regret it.
Perfect. And do you have like training programs for like fellows in retina, or is it just because it's a private center, you don't have these programs?
Yeah, it's not a private center, it's a federal center. It comes from the tradition of the miners. So it has been a miners' hospital. And since 60 years, it's open for the public, so for everybody. Because here in the southwest, in Saarland, it has been one of the two largest minor centers in Germany, and it's still a heavy steel, so it's heavy industry here in this area.
Interesting. And what is your hometown? What is your original hometown in Germany?
Yes.
Is it the same place or is it a different town?
Yeah, or no, I'm not here from Saarland and not from Tübingen. I originally come from Cologne, from the Cologne area. So there where I've done my residency with Klaus Heimann, it's about 3.5 hours travel.
Perfect. Can you tell us, for anybody visiting Germany for the first time, what is a must-see attraction or must-see city or cities, if you like, for people that haven't visited Germany before?
Yeah, of course, everybody knows the main travel spots like Munich, Berlin, Heidelberg, and I can assure you Sulzbach is not on this trip. It is really a miners and heavy industry area, which is very interesting in the cultural view and also in the living quality, because we are highly influenced by the proximity to France. So eating is the most important thing here.
Okay.
And we have a lot of haute cuisine. So the Saarland people like to eat well, but it's not really a touristic spot.
And what is the most famous German plate or meal? What is Germany known for like the German cuisine? What is the most famous food there?
Yeah, so Germany is relatively large country, so we have various regions which are really quite independent and also different, and so every region has its own tradition. But what is typical for Germany certainly is the cuisine with meat.
Excellent.
Meat and sausage, I think that's what every tourist will experience.
Okay, so apart from doing retina surgery or eye surgery or doing your practice, what's your preferred hobbies? What do you do in your spare time, if you have spare time?
Yeah, my hobby is definitely ophthalmology and ophthalmic surgery. But besides that, I have a wonderful family with 2 small children, which are 8 and 10 years, and I play tennis.
Excellent. Okay. Finally, what is the most exotic country that you have visited during your travels or meetings that you have went around the world? So which country you think it was most left a print in your memory?
Yeah.
Say Egypt.
Of course, Egypt is has a very prominent place in my memory. It was a fantastic time with you, and I've traveled to Egypt in the same year a second time to another congress as well. So Egypt is certainly fascinating. Namibia is a fascinating country. South America with Chile is a fascinating country. Costa Rica is a fascinating country. I had a very nice Congress time in Hong Kong. So the good thing with research is that we all can travel a lot. So I could continue my list. I've worked in China as a student, and then at the university hospital. I've spent 3 months in China, and it's a long time ago. And at that time, I even have spoken a little bit Chinese to communicate with the patients. So this was a very nice experience, especially because back in the 90s, China was different and not that westernized like it's maybe now.
Absolutely. So anyway, thank you, Peter, for this brief introduction and getting to know you a little bit better as a person. We will take a short break, and then we will come back to discuss our main topic, which is the subretinal pyxium implantation for bionic vision in AMD patients with end-stage geographic atrophy. We'll take a break and we'll come back again. Don't go away. Once again, we welcome you, and now we were going to discuss the topic of today's episode with Professor Peter Schurman about bionic vision for end-stage AMD patients with geographic atrophy.
Thank you again for giving me the chance to present a thrilling topic, to my opinion, a thrilling topic, because still we have no real treatment for dry AMD. Yeah. So we have a lot of progress in the treatment of exudative AMD, but we forget that there are even much more patients which suffer from dry AMD. And here I would like to present the first pyxium implantation to treat geographic atrophy in AMD, and to present the PRIMA study. It's a European multi-center study. So the bionic vision, or respectively the neuroprosthesis, is the topic what I'm involved since 25 years. And everybody knows neural prosthesis from retina implants for hereditary dystrophies, which don't really work anymore. But just for 1 minute, I show you my background. I had the chance to work in 3 research projects which addressed the research of retinal prosthesis in Bonn, in Cologne, and in Tübingen. And here in Sulzbach, we have implanted the American Argus 2 system. So in Tübingen, we have developed the Retina implant, which is a subretinal implant. Here to the right, a commercial video. So we've progressed quite a lot. We have a lot of patents. And when we started in 1996, then we had a prosthesis with 2 electrodes. And now we have 1,600 electrodes. So it was a quite good progress. And at the end, I've collected several experience with both with the subretinal tubing microchip and with the epiretinal American microchip. Both systems are not in the market anymore. And this shows that there is a lot of technical problems to implement neuroretinal prosthesis, and the disease was problematic because it was only limited to hereditary retinal dystrophies with a very limited number of patients. And what I would like to talk now is about a similar system, but which addresses geographic atrophy and macular degeneration. And here we have a much larger number of patients. And there is still an unmet need for this disease. Basically, we're talking about those patients to the left, a small one to the right, an end-stage geographic atrophy, with complete atrophy of the macula. And the aim is to implant a subretinal chip directly in the atrophic defect. And this chip is stimulated by a laser and gives electronic stimulus to provoke evoked potentials to the retina. And the system is quite evolved. We have the PRIMA retina implant system, which consists of these glasses here and a pocket computer and an implant, which is implanted in the subretinal space. The system works by receiving the image with a CMOS camera, which is built in the glasses. Then it transmits the information to the small pocket computer. It goes back the signal to the glasses where a small infrared laser is installed, and this laser wirelessly provokes this subretinal chip, and this chip can act as an artificial retina. This is the first patient we have implanted. It was the first patient in Germany last year. You can see on the right how it works. So the image is really transmitted to these pixels in the subretinal space directly in the macular area. This is the commercial video. I just use it because I would like to show how the main steps of implantation are. The good thing is that implantation is much easier than the former prosthesis for dystrophies. It's only a 1.5 hour prosthesis with a preloaded system. You have a small retinotomy and directly injected under the retina. And we have started a European multi-center regulatory study with a lot of studies. The first preliminary study has shown with 7 patients in France and US that it basically is safe and feasible, but it was only a feasibility study. And now we have started with a large multi-center European study. In Germany, there are 6 centers, also Bonn, Ludwigshafen, Hamburg, Munich, and Tübingen, together with Sulzbach. In total, 38 patients will be recruited, and there are very severe inclusion criteria, so only progressed atrophy are included with very minimal vision in the better eye, and we are planning a follow-up time of 36 months. So in Europe, Paris had implanted the first chip in Europe, and then we've been the second. We've implanted 2. And after that, currently we have 1 implantation in Lyon in France and 1 in Bonn, Ludwigshafen, and a few months ago also London. The inclusion criteria have been strict, but we had a very large advantage to recruit our patients. We were that fast because we already had our sugar AMD register, where we have included 160 patients since 4 years. All patients very standardized with such a disease of geographic atrophy, where we follow the patients up twice a year to prove an advance and to identify a rapid progressor. And when the Primavera study came up, we already had 160 completely characterized patients, which we have known since at least 3 or 4 years. Most of them were also genetically characterized, so we could recruit our patients quite fast. It was quite extensive, the surgeons training in Paris. Every surgeon in the Primavera study has to do 2 implantations in the living pig, which was in springtime last year. And in summer or September, we had the first 2 implantations. So here I show you how the implantation works. First, we start with a subretinal injection of BSS, and it's absolutely impossible to release, even to detach the macula, because it's completely scarred, and you have to release the retina with a sharp instrument to release the scarring. And once the retina is released, here we have the microchip. And it's a bit tricky because this microchip must immediately, after the subretinal injection, must be stabilized with heavy liquid, with PFCL. Then the chip is under the retina. And now we need to position the chip more to the center, so to push it more to the center as far as possible. In most cases, it's not possible to completely achieve the fovea, because the fovea is mostly completely thin and even more scarred, and it's absolutely mandatory to avoid a macular hole. So the chip mostly is directly adjacent to the fovea, but this is enough. And here we have the 3 months results under silicone oil. The silicone oil is now released now. Here is a second patient. It's completely, not minimally invasive, but it's quite easy surgery compared to the implantation in hereditary retinal diseases. And here I show you the performance training. We are unfortunately not allowed to show our results of our training because it's an ongoing study and it's forbidden to publish or to present in concrete information, but we are allowed to show the clinical training from Paris with a patient that had already an implantation 1 year ago, and you can see that this patient can read or at least identify such small numbers, which is certainly quite a good result. Here another patient who is asked to read this, and again you see it's small letters, and the patient is able to read the French word poisson, so for fish. But we have to admit, and you can see it very realistically in the video, that the patient doesn't read all the words in total, but he reads letter by letter, because the visual field is minimal, and still the patient is searching his fixation point. But we are talking about nearly blind patients before implantation, so it's really a progress. And this is an accredited image of our own training 2 weeks after Power On, of our own rehabilitation training. This is the only video which I'm allowed to show because it's not exactly showing the performance of the training, but here the patient can read the letter A. So the best visual acuity of a patient is under normal conditions with a wide field situation is 4%, so 0.04 visual acuity, or logMAR 1.4, but we have a zoom function. So if the patient wants to read, he can zoom and can multiply the vision up to a visual acuity of 0.32. So it's the best vision I have ever seen for neuroprosthesis. Okay, so we are at the end, but the development of the microchip is not at the end. We are just at the beginning. I think geographic atrophy and AMD is the right target disease, and we have to improve with several steps the performance of the chip. Currently, we have only 378 pixels on this chip, which is not a lot. But we are already at 1,500 in preclinical studies, and it is already planned and technically feasible to develop microchips of 40,000 pixels with a pixel size of 10 microns, and this will certainly dramatically increase the performance of reading. Yeah, so this is again the final slide. This is a target disease, and those patients we are looking for an atrophy or at least 2.5 millimeters, so about 1.5 optic nerve diameter, and vision is 0.063 in the worst eye. Thank you very much. I hope that you're also thrilled like I am with this new development in geographic atrophy.
Thank you, Peter, for this very nice presentation and very promising technique. I hope it proves to be useful on the long term with the development of the microchips. Just a few questions. Of course, this is still an investigational prosthesis. I mean, it's not commercially available to be used by other surgeons like in Europe or in the US. Is that correct?
Yes, but in total we have about 35 or 40 centers in Europe, and there is a planned study in the same dimension in US. So a lot of patients will be included, and it's not commercially available, but it's open for treatment for patients here in Europe.
The other thing, one of the biggest obstacles for retinal prosthesis when it will be available commercially is price or cost, because many patients, like maybe in Egypt or in the Middle East or wherever, when they think about doing it, it's quite expensive. So is there a forecast for a cost that is acceptable for patients? Because to my knowledge, the previous prostheses were like almost 100,000 euros. Is that correct? Correct me if I'm wrong.
Exactly. The last prosthesis was 90,000 euro, yeah, so about 100,000 US dollar. So it's really a lot. I have no information about the current calculation of Pixium, which is a French company based in Paris. And I think that it will be slightly cheaper than these 100,000 because the system is not by far not that complex like these retina implants for hereditary diseases. But still, it's an expensive system, definitely.
What is really intriguing about this prosthesis is it looks as if the surgery is somewhat simpler than previous prostheses, and it takes shorter time, as you mentioned, like 1.5 hours, with a cartilage to inject something very similar like Ozurdex. The question is, are there any complications other than the risk of macular hole formation, as you mentioned, because of the scarring? Did you meet, or if you are allowed to say this information, of course you can refrain if you like, but if there are other complications like rejections, like dislocation, other than just macular hole formation, if it happens?
Yes, so the long-term complications seem to be not the main problem. It's still a question of intraoperative complications. And there are several which are possible. First, bleeding, because we need retinotomy temporal of the macula. And the second is that the microchip is very light, and it flies away directly if it is out of the injector system, and it's not managed to be in the subretinal space. And then you have no chance to get the chip again, because due to the BSS circulation in the vitreous, the chip is flying in the vitreous. So you have to stabilize it with PFCL. And the most important complication are macular holes. So you have really be focused on avoiding macular holes during preparation.
Okay, the other thing you mentioned that you use silicone oil. Do you keep it like for a short period, or is left indefinitely? And how big is the retinotomy that you create in order to put your implant under the retina? Is it a big retinotomy and you laser it?
Yeah, so the chip is 2 millimeters, and we need a retinotomy which is a bit larger than 2 millimeters. The good thing is that you don't need a laser or a diathermy, because it's a very central retinotomy. You have seen on the image that one of the two patients had a very slight bleeding around the retinotomy, which disappeared after 3 months. But it didn't pose a problem, and PVR seems to be no problem. I mean, these two Sulzbach patients have been the number 9 and 10 worldwide of implantation. So the number is still limited. But for the 7 patients of the preclinical study, there we have long-term results of more than 3 years, and we have no PVR in any case.
And you remove the silicone oil or you keep it indefinitely?
No, a very important question, because with the retina implant prosthesis, we needed to leave it long life. And here we have removed it in both cases after 2 months without any problems.
Okay, final question now. This implant, is it specific only for end-stage dry AMD, or can it be also used in hereditary retinal diseases like retinitis pigmentosa? Is it just specific for AMD?
It's a very important question, because we are, of course, in the advisory board, and the involved surgeons discuss continuously those questions. And currently in this study, and for labeling, it's limited for geographic atrophy in dry AMD, non-hereditary AMD. But the most interesting alternative target disease is, of course, the Stargardt, for example, Stargardt disease and other hereditary maculopathies. And one important thing or advantage of those patients is that they are much younger than the classical AMD patients. And it's different to do the surgery on a patient with 75 or 80, in contrast to a patient which is about 55 or 60. And I also think that the Stargardt patients or the other hereditary patients have a chance to perform better. But currently it's only limited for the classic AMD.
Peter, thank you so much for this comprehensive presentation and the great discussion and information that you have conveyed to us. It's really a pleasure that we had you on board during our visit to Germany, and hopefully we can have you in person again in Cairo in the near future. Really thank you. The Egyptian Vitreous Society is really happy to have you again and again and again. We really learn a lot from you. Thank you so much, Peter.
Thank you, Sharif, and I hope to welcome you also in Germany. You're warmly invited.
Okay. Thank you. Thank you so much, Peter, and see you soon. You have a good day. Bye-bye.
Bye.
Bye-bye.